Indications: ozone, a better alternative in COVID-19 pandemic in Journal of Recent Advances, Spain 2020. And he has he has an article on platelet-rich plasma for shoulder joint, a review article in Recent Advances, Journal of Recent Advances, Spain, published in 2019. So over to you, Dr. Javed. We are eager to listen to you. Already there is a lot of delay. So please proceed.
A very good evening to one and all. I'd like to start with a big thank you to Archana ma'am for a wonderful introduction, and to everybody who has joined the meeting as well. So a very good evening. The topic for today is palliative interventions, a very interesting topic indeed, and we'll try to touch base on most of the aspects required for this particular topic to be covered. So this is going to be the contents of my presentation. We shall start with a brief introduction. Then we'll go into the scope of palliative interventions, the various interventional techniques, the psychosocial aspects, the spiritual aspects, a couple of case studies, and finally we shall conclude. So if you look at palliative care, it's defined as mainly a focus on relief of the symptoms, right? Relief from symptoms and the stress of a serious illnesses. Could be cancer pain, could be a severe chronic pain, etc. But the focus is not on the curative part, but it's on the relief from the symptoms and the stress. The goal of palliative care is to improve the quality of life for not only the patient, but also the families. And if you look at the role of interventions, well, it is more relegated towards pain and symptom management, holistic support, and dignity in care. Coming to the scope of palliative interventions, well, primarily it is for symptom management. Symptoms could be anything like pain, breathlessness, nausea, fatigue, etc. Interventional pain techniques for advanced cancers and chronic conditions, enhancing comfort when curative options are limited, especially when patients have been shown that the curative pathway is almost deficient. There's not much which can be done. Then comfort care is what is going to be the target and goal. Supporting patients across home, hospice, and hospital settings, integrating medical, psychosocial, and spiritual care. Now, coming to the interventional techniques or the pain-related procedures, what we can call, many other. I'm just trying to name most of them. We have nerve blocks, right? So nerve blocks in the sense we have sympathetic nerve blocks, like for example, splanchnic plexus block, hypogastric plexus block, celiac plexus block, ganglion impar, intercostal nerve blocks, etc., etc. So nerve blocks can either be done by a local anesthetic, okay, as a diagnostic block, right? And then followed up after a positive diagnostic block with a neurolytic technique. Neurolytic techniques could be either neurolysis with alcohol, phenol, or radiofrequency ablation. Okay. Now, of course, we know when we are using alcohol or phenol, it is more of neurolysis what we are doing. But of course, the duration of action is variable. Phenol is the shortest comparatively. And then next comes in alcohol neurolysis, and then followed finally by radiofrequency ablation, which comparatively provides a longer duration of pain relief. Intrathecal or epidural drug delivery systems are also there in patients. And of course, vertebroplasty, kyphoplasty for painful bony metastasis are also present. Now let's have a look briefly at the various interventions. Okay, not going to go too much into details of the steps over here. Just we're trying to see what all intervention techniques are there. We have the splanchnic neurolysis, which is commonly done for the upper abdominal malignancies, upper abdominal chronic pains. Okay, here you can see the greater splanchnic, lesser splanchnic, and the least splanchnic nerves, and the target. Of course, these are going to go and confluence into the celiac plexus later. So this is a splanchnic plexus block being done for a patient with pancreatic malignancy. Okay, of course, we target around T11, T12, okay, region. And this is the needle which you are seeing done bilaterally, okay. And once you have the needle at the right spot, that is a junction of the posterior 2/3 and the anterior 1/3, or just behind the lateral border of the vertebral body at T12 or T11, you're going to inject the dye and get a confirmation with the dye, okay. And then you're going to do neurolysis, either alcohol, phenol, or RF. Celiac plexus block is also done. Okay. Again, for the upper abdominal malignancies only. And in celiac plexus, primarily, it is not much of an RF which we can do. We can do the alcohol neurolysis over here. Reason being, it's quite a large ganglion. So with an RF, trying to cover most of the celiac plexus becomes practically difficult. Okay. And that's why alcohol neurolysis or phenol neurolysis, alcohol is more preferred in neurolysis for celiac plexus block. And of course, whenever we are doing the alcohol neurolysis, once the neurolysis has been done, then you have to flush the needle with a saline or local anesthetic and then withdraw the needle back. If not, if it is just withdrawn back like that, only the alcohol which is still there trapped in the needle lumen can trickle over and it can cause a severe kind of a burning pain, which needs to be avoided by flushing out the needle first. Stellate ganglion block, usually for head and neck neuropathic pains, malignancies, etc. Stellate ganglion block can be performed. Of course, we have either the fluoroscopic guided technique or the ultrasound guided technique also, which is there. Trigeminal neuralgia can occur as one of a complication of any of the head and neck malignancies in case there is any secondaries involving around the Gasserian ganglion. So it can lead to severe trigeminal neuralgia. And in that case, in case of intractable trigeminal neuralgias, we do the Gasserian ganglion block. Of course, over here, RFA is what is preferred. Again, this is a fluoroscopic guided technique. You can see the foramen ovale over there, okay? And the needle which is being directed through it, depending on which branch is involved, either V1, V2, or V3. And the RFA is carried out. This is a lateral image of the Gasserian ganglion block, okay? And remember, the needle should be directed towards junction of clivus and petrous part of temporal bone. Sphenopalatine ganglion block again is a very good option, especially for sympathetic pains around the face, right? So it is performed and it helps take care of most of the neuropathic pain conditions. Again, this is the fluoroscopic guided technique wherein the sphenopalatine foramen is targeted through a lateral approach and then the needle is directed towards the root of the nose. Okay. T2, T3 sympathetic block is performed primarily for cancers which lead to neuropathic pains affecting the upper limb, chest region, etc. And performed at T2 level and T3 level. Sympathetic block again, okay, wherein the needles are targeted towards the middle of the vertebral body. RFA can be done over here, okay, it is more better. This is a T2 T3 sympathetic block. It's being done. For patients having cancers and they're having, severe lower limb involvement, okay? Sometimes it also, not only cancers, could be peripheral arterial diseases, Buerger's disease, etc. The lumbar sympathetic block is very much preferred in these kind of patients. And again, the fluoroscopic guided approach is there over here. Then at L2, L3, and L4 levels, and either RFA or alcohol neurolysis can be performed. Superior hypogastric plexus block for chronic pelvic pains or any cancers affecting the pelvic region, be it in the female population or in the male population, right? So it's again an approach which is used to help people who are suffering from these kind of problems. This over here, you're seeing the transdiscal approach at the L5S1. A lateral approach also exists wherein the plexus is targeted. Once it is done, a dye is injected and you confirm the dye spread and start the lesioning. Again, either a neurolysis or an RF. A ganglion impart block is also preferred, especially for the perineal kind of pains. Okay, so it's again a very good option. Okay, which can be performed in case of these patients. Again, coccydyna is another kind of indication for this. If there is any metastasis around the bony region around over here as well, you can think of these particular options. For ganglion impaired block, what is usually preferred is something called as a bipolar RFA or a bipolar radiofrequency ablation. You can see over here 2 needles are being placed, okay? And once they are placed, you're going to inject that dye. You have to be very careful over here in this kind of procedure because you cannot go very deep. The needle, you have to go forward millimeter by millimeter, and because in front rectum is there, so rectal perforation is a very dreaded complication if not much of expertise is there, or you do it, or if you do a very rough procedure. So you have to be very careful of this complication. Patients who have compression fractures, in them vertebroplasties are performed. The vertebrae wherein the fracture is there, again that is targeted, and the bone cement is injected into the vertebrae. Kyphoplasty is again something similar to vertebroplasty only. Only thing is over here, kind of a balloon is created, okay, and into that the cement is injected. Helps reduce the pain almost instantaneously. Intrathecal pumps are also there, okay, wherein the catheter is inserted into the spinal column or the intrathecal space, and the pump which is there, it is implanted under the skin. So this is again one of the advanced interventions. So apart from the interventions, well, psychosocial aspects are also very important to address, because what happens in these kind of patients, right? When you are trying to adopt a palliative approach, a palliative pathway, interventions are going to, yes, definitely help, but they are not the primary thing. That's what you have to keep in mind, because it also has a limited role. You cannot promise the world for patients with just interventions, because this is a total pain, right? So you have to tackle each and every aspect of the pain condition. Psychosocial aspects are very important, which needs to be tackled. You have to address the anxiety, the depression, and also take care of the caregiver also, because caregiver burnout is a very important phenomenon which happens. So caregiver stress needs to be addressed. Family counseling and support needs to be done, especially regularly with the patients, because they, not only with the patient, but the patient's family as well, attenders, they need to be in loop about what expectations to have in these kind of patients. Communication of the prognosis should be done, but yes, it should be done with a layer of empathy for these kind of conditions. And social work support, be it financial, be it community resources, etc., should be provided easily. Coming to the spiritual aspects, you have to have the respect for the patient's faith, values, and the meaning of illness. Try to facilitate to spiritual counselors, okay, or chaplains. Provide environment for rituals, prayer, or reflection, because again, the spiritual aspect of pain is very important to address, and it is often neglected. And what this does is it enhances the dignity, and it provides a sense of peace at the end of life. Now, the certain outcomes which we need to keep in mind, and those are, in, for example, if you think of pain relief, then whenever you have done any intervention or started a medication, then you have to measure it, right? And the measurement of the pain intensity is done by either the VAS score or the NRS scores. Decreased breakthrough pain episodes are very important. Okay, so you can make a note of how many breakthrough pain episodes were there prior to the intervention and know how many they are. And reduced opioid and analgesic requirements. This is going to be the target of any intervention, what you're planning to do. You cannot promise 100% pain relief. Okay. And even after doing the intervention, still the background medications have to be continued. They should not be stopped. Patient should not feel like, okay, the intervention is done, over. Now that's it. We don't have to worry about the pain at all. That's not the thing. Intervention is done to break the pain cycle. But still, the other opioids analysis have to be continued. Functional outcomes, that is measured by improved mobility and activity tolerance by the patient, better sleep quality, enhanced ability to perform activities of daily living, the ADLs. Quality of life, well, that outcome you can see by the emotional, looking at the emotional well-being of the patient and reduced anxiety, improved appetite, better energy levels, and elevated mood, dignity and comfort preserved even in advanced illnesses. Patient and family satisfaction is assessed by better communication and involvement in care, relief that suffering is addressed holistically, and higher satisfaction with the overall healthcare experience. Healthcare outcomes, they measured by one, reduced ER room visits, reduced hospital admissions, less reliance on aggressive or futile interventions, cost-effective care without compromising dignity. Now, let's have a look at a couple of case studies. Okay, so case one, for example, if there is advanced pancreatic cancer. Okay, so patient can present you with severe epigastric pain, radiating towards the back, uncontrolled with opioid. This is a very characteristic presentation. So the intervention of choice, you can choose a splanchnic neurolysis or even a celiac plexus neurolysis also done under fluoroscopy. And what is the outcome? Outcome, significant pain relief within 48 hours, opioid dose reduced by more than 50% and improved appetite and sleep. So what you are seeing over here is the outcomes measurement are measured after the procedure, not just by the pain relief only. Significant pain relief means, of course, more than 50%, more than 70% of pain relief is very vital within 48 hours. Reduction on the opioid dose, more than 50% is important, and improved appetite and sleep also are very, very important. Okay, this is one case. Second case, very common again, is vertebral metastasis in the breast cancer patient. For example, we have a 62-year-old female with breast cancer metastasis, severe back pain and immobility. Okay, so a vertebral compression fracture was there. So intervention chosen was a percutaneous vertebroplasty. Outcome, immediate pain reduction, and the patient was not able to get up, was bedridden literally, started ambulating within 24 hours. So what it has resulted in is one, improved quality of life because the patient is able to ambulate, and reduced caregiver burden as well. So to conclude, palliative interventions are not just about prolonging life. They are about improving the quality of life, which is very important. A multidisciplinary, compassionate, and patient-centered approach is definitely going to be the key. Palliative interventions are not similar to the other pain management interventions, what we are doing. Over here, we need to do or adopt a very layered approach, because it is not just a focus on reducing the pain, but also addressing the various other domains, addressing the biopsychosocial model as well. Thank you very much for patient hearing. I conclude my presentation. Ma'am, you're not audible. Ma'am, you're muted. Archana, ma'am, you are muted, ma'am.
Hello. Yeah.
Yeah, now you're
Am I
audible.
audible? Yeah. That was really a crisp presentation, I must say.
Yes.
So we'll take the questions that are there in the chat box.
Yeah.
Okay. So let me see the chat box. There is one question.
Yeah.
Sir, what are the complications of neurolysis with alcohol?
Okay, so usually alcohol-related complications, one thing I had told you is one thing is there can be local pain or burning during the injection. Okay, if there is a nerve around, it can lead to neuritis as well, and sometimes paresthesias or dysesthesias, etc., can also occur. Systemic complications, if you see, of course, there can be hypotension sometimes. Of course, due to the due to the sympathetic blockade, that is hypotension, bradycardia, diarrhea, etc. So specifically, yeah, these are a few other complications which you have to keep in mind.
Yes.
In your practice, would you choose alcohol neurolysis or RFA? They have asked. So it depends on which sympathetic block we are doing. As I told you, if we are planning to do a celiac plexus block, then I would choose an alcohol neurolysis or an RFA because it's a larger ganglion. Whereas if I'm doing a trigeminal neurolysis, then I'll prefer an RFA. No doing alcohol over there, because you have to be sure that there are no important structures around, right? Because alcohol can spread to the other neighboring structures as well.
Next question is, what intervention for cancer lung and cancer breast?
So cancer lung and cancer breast, basically, we have to see, usually there is bone metastasis, skeletal metastasis quite prevalent in these kind of patients. So if there is any vertebral compression fractures, then you can plan for vertebroplasties, right? If not, if there is kind of a neuropathic component, you can plan for the T2, T3 sympathetic block. Of course, sometimes paravertebral nerve blocks, intercostal nerve blocks can also help the patient in case these things are not accessible to you.
Okay. Why does RFA not preferred in cancer pain?
RFA is preferred. RFA is, I'm not telling RFA is not preferred. It depends on which sympathetic plexus you're blocking. If you're doing a splanchnic neurolysis, I would prefer an RFA. If you're doing a trigeminal, I would prefer the RFA only, not the chemical neurolysis. Okay.
Okay. Next.
Why chemical neurolysis is restricted to cancer patients only. Again, not specifically restricted only to cancer patients. Nowadays, if you see phenol neurolysis, a few studies are coming out wherein people have been doing knee RFAs with, knee neurolysis, genicular nerve neurolysis with phenol. So especially that is another new kind of a thing which has been coming. So we are not restricting neurolysis only to the cancer patients. If vertebroplasty or kyphoplasty is not possible, what is the modality of choice? Okay, if vertebroplasty or kyphoplasty is not possible in a vertebral compression fracture, well, you have to then manage with what you have in hand, because the pain will be very severe in these kind of patients. For skeletal metastasis, morphine is a very good option to try. Multidisciplinary, multimodal approach with opioids, NSAIDs if they are not contraindicated, right? And then the co-analgesics, anticonvulsants, antidepressants can be tried. Of course, you can ask the patient to wear a brace as well. Okay, that also kind of helps the patient. So physical rehabilitation also plays a very vital role. What percentage of alcohol is used? Well, they tell absolute alcohol is what we use. Okay, so around 90%, 95% is what we use for the chemical neurolysis. Of course, we do mix with the local anesthetic sometimes, and then the distilled water as well. And can we use phenol for chemical neurolysis? Yes, we do use phenol for chemical neurolysis. Due to posterior cortex breach, cement leakage. Well, if that happens, it's an emergency. That is the reason why whenever you're doing a vertebroplasty, you need to be very careful that the posterior cortex is intact. First, you do the CT or you do the MRI. You first confirm if the posterior cortex is intact. Okay, then only you go ahead with the vertebroplasty. If still there is a leakage, which can happen, then you have to have a neurosurgeon ready with you who can open up, because that is a real grave complication which needs to be addressed as quickly as possible. Alcohol versus phenol, which is better? Definitely alcohol is more better because of longer duration of action. Phenol advantages are, one, that you don't need to inject a local anesthetic when you're using phenol. It has inherent local anesthetic activity. In case of gallbladder cancer, gross ascites, hyperbilirubinemia with diffuse abdominal pain, what shall we do? Okay, gross ascites, many a time what happens is that itself can be a cause for the pain because of the pressure symptoms. So you can take the help of interventional radiologist and ask them to do an ascitic tap. If it is accumulating again and again, you can ask them to put in a pigtail catheter, which can keep, removing the ascites whenever it is coming. So yeah, you have to follow the multidisciplinary approach in these conditions.
Okay. So in cancer, we all can say that there is no single treatment that is a thumb rule for everybody. We have to subjective treatment for all the patients and a total holistic approach, right?
Very true, ma'am.
Yeah. So I think the questions have ended. That's a good thing that the questions are got over. There is one thing that I wanted to ask. Many a times for CA lung patients or even CA breast patients, there are vague pains which is there in the upper back, which is there in the lower back, and the middle portion there is no pain. Something like these are also common. So uh, there are some papers which say that erector spinae, I mean the nociceptive blocks are also useful rather than just sympathetic blocks.
Yes.
What is your experience with such I mean analgesic or nociceptive blocks, not only sympathetic, like
So many of
are
our time,
you
yes, ma'am. So the somatic blocks also help a lot,
somatic? Yeah.
especially these kind of patients. They tend to develop a lot of these muscular spasms, be
Hmm.
it the spinae, the rhomboids, and everything. So the ESP plane block definitely helps. If there are some muscles can go into a lot of actually trigger points as well. So sometimes localized trigger points can also be addressed over there. Paravertebral nerve blocks, intercostal nerve blocks can also help. And one important thing in these kind of patients is the physical rehab aspect.
Hmm.
Especially physiotherapists or physical rehab specialists can help these kind of patients because
Hmm.
also of the weight loss which is happening, they become emaciated as well. The
Hmm.
muscles tend to become very weak, because of which they tend to go into repeated involvement of spasms and everything.
Uh-huh. Okay. Very true, sir. Very true, Dr. Javed.
That's fine.
Okay. So I don't think there are any questions anymore. You have actually elaborated everything point wise. So, okay, one question, splanchnic neurolysis in place of celiac plexus. You have actually explained, but okay, we can
Yeah.
answer that again.
Yes, so it depends actually, because splanchnic, there have been studies actually who have compared splanchnic nerve neurolysis and celiac plexus neurolysis almost equivocal, but splanchnic nerve definitely has an upper hand. Reason being over there is because you can do an RFA for a splanchnic nerve, which will give a longer duration of pain relief. Whereas celiac plexus, you have to do a neurolysis only. And the technique itself, when you're doing a celiac plexus, either you go a transaortic technique or a lateral technique. So that also you have to be very careful of the complications which can occur. So yeah, either this or that. But if you want a longer duration, if you're looking, then splanchnic nerve neurolysis by RFA, I would definitely prefer.
But there is one disadvantage, Dr. Javed, that whenever the pain is generalized in the abdomen, it is not just restricted to epigastric pain.
Yes.
Uh, some pain even lower down, then I think celiac plexus helps better to relieve that. And
Yeah.
splanchnic doesn't relieve all of that pain, right?
Yes.
What is
Yes.
your experience?
My experience is, yes, ma'am, very true. It the celiac plexus over there scores a little bit higher, and also
Hmm.
in these kind of patients who have ascites, it becomes very
Hmm.
difficult to make them lie down prone. So,
Yeah,
to find position if you have to do, then celiac plexus only can be accessed. Splanchnic, it will be very difficult to access. So, ultrasound guided celiac plexus block can be done in those kind
hmm,
of patients as well.
right.
Okay, is a combination of alcohol, neurolysis of celiac plexus and splanchnic RFA more effective? Well, then we have to be very careful over here that whenever you're going ahead of a neurolysis, primarily first you have to do a diagnostic block. And in the diagnostic block, you will understand how much of a relief the patient is having before going into or neurolysis in itself. So combining both, again, I'm not very sure because there'll be a dual sympathetic block, more of a sympathetic block, again, more of hypotension and all that. So I would more prefer doing it actually step by step. Do first either a celiac or a splanchnic and then see how it is. First a diagnostic block and see which one is more better. If the patient is having good relief, then you can go ahead with a neurolysis.
Yeah, actually, there is no need if you are given celiac plexus, then
Yeah.
separately splanchnic RFA really doesn't
It doesn't,
take
yeah,
any, I mean, advantage as such. Splanchnic you're doing to avoid celiac actually, not to.
correct.
So doing together doesn't make a one after the other is the right choice.
Yes. Okay.
Okay.
So, will most of cancer, lung and CA breast chest pain radiating back respond to T2 chemotherapy? Okay. So again, as madam was just discussing now, Many of the time, the pain which radiates to the back in CA lung and CA breast could be because of the muscular component as well. So, a somatic nerve blocks can definitely help. Not all will be taken care by just a sympathetic block. So, I would say you can combine a bit of somatic blocks also over here.
And especially because T2, T3 are technically difficult, plus they have some
Yes.
kind of pleural effusion all the time. They generally have these patients because of that growth, especially the palliative CAs, where the recurrence has taken place. Pleural effusion, mild pleural effusion will always be there.
Yes,
So
correct.
it becomes very difficult, T2, T3. I mean, what's your experience? I really feel scared in such patients because.
On T2, T3, I usually patients who can lie down prone. I
Hmm,
usually go ahead with the T2, T3 only if there is a neuropathic component.
hmm,
If it is more of a nociceptive component, just the somatic blocks, the paravertebral blocks, the ESP blocks can be more than sufficient with these kind of patients than
oh,
attempting something so difficult.
okay, okay. You also face problems with T2, T3 as compared to our other sympathetic blocks. Is it
Uh,
technically?
One thing, ma'am, with T2, T3, yes, what happens is many of a time that to reach the vertebral body, the T2 or the
Hmm,
T3 vertebral body, it becomes slightly difficult because there
hmm,
can be either some kind of osteophytes if it is an elderly person, or the
hmm,
processes itself, because the spinous processes and the transverse processes, especially transverse processes, can
hmm,
walk in the way. So that becomes
hmm,
slightly difficult, and you're so close to the Pura, the lung, that in itself
hmm.
becomes a bit of a proposition.
Causes pain, right? Yeah. The moment you touch pleura, it causes pain.
Correct.
Okay. What will be the option for a light thick lesions in humerus
Before
skeletal?
that, there is one question. Is differentiation pain seen as a
Ah,
complication in both RFU and alcohol neurology? Yes, it is seen. So,
hmm,
differentiation pain you have to be careful of. One way to avoid it, what is told is post lesion, you just inject a little bit of steroid. So,
hmm,
that is one thing which can avoid differentiation pain. And one very important thing is to keep the patient informed that, this is one complication which can come. So if they are
hmm.
aware of it, then it will be more easier to handle for both the patient and yourself also.
Yeah, right.
What is the
And the
option
last one.
for a lytic lesion in the humerus, skeletal mets, and painful shoulder? Can we do suprascapular analysis or any other insight? Okay. So yes, if there is a lytic lesion in the humerus, definitely you can try a suprascapular neurolysis over here. Also, one more thing is if it's a painful shoulder, severe amount of pain, you can also think of shoulder RFA as well. Not only the
Hmm.
suprascapular, you can also plan for axillary and lateral pectoral also. If it is
Yes,
those areas are also involved.
yes. Just suprascapular will not be sufficient. That's very nice. Very correct. Hmm. Okay, I think we should take say goodbye on these particular questions. We have actually you have answered almost all the questions,
Yes, ma'am.
and that too satisfactorily. So
Thank
those who really want to ask anything, Dr. Javed is always there to help us as an
you.
IIPM faculty. So thank you so much, Dr. Javed, for that wonderful presentation and wonderfully answering those many questions. And thank you so much, everybody who are all attended this session. Thank you so much, Dr. Javed from
Thank you.
IIPM.
Thank you so much, ma'am. I'd like
Really
to
wonderful.
thank Archana, ma'am. She's always been a wonderful moderator, and very happy that I got a chance to do with madam's moderation. It is the second time which I had this opportunity, and it's always a pleasure, ma'am, to have you as a moderator.
Measure is dual, yeah, both sides. Thank you.
And
Thank you so much.
uh, uh, and also all the IAPM candidates, I'd like to wish them all the very best for their classes and everything, when their exams also. I think it'll be in December, Jan maybe. So close towards that they are moving. All the very best for you all, because I myself was there in their shoes a few years ago. I can feel the pressure slowly building up. But yeah, with all the preparation and all, I'm sure all of you will do well. Thank you very much. Wishing you all the very best. Thank you.
Candidates, you have got a very good teacher here. So keep in touch with Dr. Javed.
Thank you so much.
Thank you. Thank you so much. Thank you, everybody.
Good night.
Yeah, good night.